There are numerous people across the country suffering from different terminal illnesses or life-threatening injuries. I'm sure we all know, dealt with, or are close to someone who's in the final stages of their life due to a terminal illness. Unfortunately, I've seen it all too much in my own life and think that there are other medical options have failed and there's literally no hope for medical recovery. Then physician-assisted suicide should be allowed by law. Terms such as physician-assisted suicide, death, and physician-assisted suicide are synonymous. However, it is best described as a physician accepting a terminally ill patient's request to end their life by prescribing lethal medications. I'll group my arguments regarding the practice into beneficence, non-maleficence, and anatomy. Let's talk about the principles of physician-assisted suicide and what the laws currently are in regards to this topic. Physician-assisted suicide is currently legal in 5 states. Those are Vermont, Oregon, Washington, Montana, and New Mexico, but court-mandated in Montana and Bernalillo County, New Mexico. In recent years, passionate debates have emerged regarding this issue, but its statutory inception began in 1997 when Oregon passed the Death with Dignity Act, allowing physicians to aid in ending terminally ill patients' lives. This was the framework and groundbreaking act which helped to later legalize physician-assisted suicide in Vermont and Washington between 2008 and 2013. New Mexico has passed a similar act, which was appealed in 2014, and is expected to receive a final decision at some point in 2015. There's a sound procedure in place in those states that have legal physician-assisted suicide. While some states slightly vary in how physicians' suicide works, they all generally provide the same 5 requirements in order to carry out physician-assisted suicide. The patient must be of sound mind at the decision to die. 2 doctors must confirm the diagnosis, which is a life prognosis of 6 months, and 2 witnesses must be presented. 1 unrelated doctor must also confirm the request, and finally, the patient must submit a second request after 15 days of being granted the first. These requirements are extremely important to note because I believe that these requirements build in numerous procedural safeguards which allow physician-assisted suicide to be carried out as is intended in a human and moral way. In other words, these procedures allow the patient to ensure that they are truly committed to this decision and that they are making a completely anonymous decision based on having an accurate diagnosis and information. Think of the worst pain that you have ever felt in your life and imagine having to feel that pain continuously. Now think of knowing that that pain is slowly killing you. Now think of your closest friends and family members having to endure watching you die. This essentially is what terminally ill patients must undergo during the final days of their lives. After all, passive euthanasia is legal and widespread according to Beauchamp and Childress. This is the practice of letting patients die through the do not resuscitate orders, which is usually carried out by the removal of feeding tubes and IVs, refusing to provide cardiopulmonary resuscitation, and discontinuing surgeries. All of these permit a leisurely and slow painful death for the patient. So how can that be moral, you might ask? There are several reasons that constitute why I think physician-assisted suicide is a morally sound and ethical decision. I believe that physician-assisted suicide is morally ethical due to principles revolving around anatomy, beneficence, and non-maleficence. As I stated above, there is a sound and a methodical process in place to eventually terminally ill patients and ensure they truly are sick and desire to end their lives before the procedure is carried out. Holman argues that there is more of a crime and oppression is committed by not giving patients the freedom to commit physician-assisted suicide. They are robbing them of their opportunities of their own life. Even though states have the power to allow and prohibit physician-assisted suicide, the U.S. Supreme Court ruled that there is no constitutional right to commit suicide. In other words, the U.S. Supreme Court does not believe that people are entitled to the decision on whether or not they can choose death to end their pain and suffering. I find it interesting that states will allow passive euthanasia processes, such as the do not resuscitate orders, yet most will not allow a physician-assisted suicide. Also, how is it ethical that healthcare workers can honor anonymous requests for refusal of treatment, which allows a slow and painful death, yet they can refuse anonymous requests for death for some grim circumstances? The principles of beneficence and non-maleficence are brought up in regards to the physicians who conduct the assisted suicide. I argue that the physicians are supposed to operate in regards to beneficence and seek ways to benefit the patient and do not cause harm to them in maleficent ways. I believe the physicians who assist in suicide are balancing beneficence and non-maleficence to the patient's advantage. They are benefiting them in ways to end their prolonged treatments, while they're also removing harm and pain, also continual suffering. Physicians are not working in poor ways when trying to help a patient end their life in order to end their suffering. Non-maleficence is when a physician removes the harm from the patient. Moreover, to be fair and comprehensive, let us see what those who oppose physician-assisted suicide argue in opposition to it. There are other arguments that non-supporters of physician-assisted suicide promote as reasoning for why it is unethical. A main argument lies in the lack of palliative care that patients receive. Non-supporters argue that if greater care is given to patients in the final days and months of their lives, then they will be more comfortable, hence less pain and suffering. What non-supporters fail to understand is that palliative care and the notion of prolonging one's painful existence is not helping the patient. The patient is making the rational decision to end their life in order to ease their suffering. Non-supporters also argue that the patient is depressed at the time of choosing death and therefore cannot be held responsible in making these decisions. There has been an established link between depression and assisted death, yet studies have shown that the correlation of these two do not prove the causation. So although medical studies have shown that there is no established link between the two, I strongly believe that people need to let those who have death deal with the unfortunate circumstances of terminal illness as they wish and not prolong their misery. I certainly understand why those oppose it. However, there is more of a human and just argument for physician-assisted suicide, provided that there are appropriate checks and balances in place to control the process. I've argued why physician-assisted suicide should be legal and show how it is legal in 5 states. It should be legal in all 50, in my opinion. While those that are opposed to physician-assisted suicide, it is legal in 5 states. In those where it is legal, there's a methodical process in which ensures a patient is truly terminally ill and wants to end their life as a result. Physician-assisted suicide is legal and moral practice for those with terminal illnesses based on grounds of beneficence, non-maleficence, and anatomy. End the senseless suffering of those already dying of a terminal illness by legalizing physician-assisted suicide in all 50 states.